If you're being evaluated for mesothelioma surgery, you might hear about neoadjuvant chemotherapy, which is chemotherapy before surgery, or adjuvant chemotherapy, which is chemotherapy after surgery. These terms may sound like the same thing, but they actually describe different strategic approaches to combining surgery with chemotherapy. Today, I want to explain exactly what neoadjuvant and adjuvant chemotherapy are, the rationale behind each approach, what research shows about which works better, and how the decision about timing affects your overall treatment plan. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician and this is not medical advice, but understanding the timing and strategy of chemotherapy in relation to surgery helps you evaluate your treatment plan. So let's start with some clear definitions. Neoadjuvant chemotherapy is treatment given before surgery. The term neoadjuvant means before the main treatment, and in this case, it means before a surgical procedure. For mesothelioma, this typically means 2 to 4 cycles of chemotherapy, usually pemetrexed plus cisplatin or carboplatin, that's given before planned cytoreductive surgery or pleurectomy decortication. By contrast, adjuvant chemotherapy is treatment given after surgery. Adjuvant means helper or addition. It's an additional treatment after the main intervention. For mesothelioma, this typically means chemotherapy starting 4 to 8 weeks after surgery, once you've recovered enough to tolerate the treatment. Some patients receive both neoadjuvant chemotherapy before surgery and adjuvant chemotherapy after surgery. This is called perioperative chemotherapy treatment. It's treatment surrounding the surgery. What's the rationale for neoadjuvant chemotherapy? Several theoretical benefits exist. Tumor shrinkage might make unresectable tumors resectable. If tumors respond well to chemotherapy and they shrink, surgery might become feasible when it wasn't initially, or borderline resectable disease might become clearly resectable. Neoadjuvant treatment provides in vivo chemosensitivity testing too. If the tumor responds well to chemotherapy before surgery, you know that regimen works for your specific cancer. If there's no response or progression during neoadjuvant chemotherapy, you know your tumor is resistant and surgery might not be worthwhile. Now, before I go on, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. Now, there are a lot of good reasons for having treatment before an operation. First, starting systemic treatment early addresses micrometastatic disease. That's cancer cells that have already spread beyond the primary site but that aren't visible yet. Earlier treatment of these cells could prevent distant recurrence. You're also going to be in better physical condition before surgery than after. Surgery causes significant physical stress and it can delay or prevent post-operative chemotherapy if your recovery is complicated. Giving chemotherapy while you're still strong ensures that you actually receive it. What's the rationale for adjuvant chemotherapy? The main purpose is eliminating microscopic residual disease. Even after complete cytoreduction, microscopic cancer cells remain. Chemotherapy after surgery targets these remaining cells to prevent or delay recurrence. Pathology from the surgery provides valuable information about disease extent, lymph node involvement, and surgical margins. This information helps tailor your post-operative treatment. Surgery might reveal that the disease is more advanced than imaging suggested, which makes chemotherapy more critical. Some surgeons prefer not delaying surgery. If the disease is clearly resectable, getting surgery done promptly rather than waiting for chemotherapy cycles to be completed removes the bulk disease sooner. What does research show about neoadjuvant versus adjuvant chemotherapy for mesothelioma? There is limited high-quality evidence directly comparing these approaches. No large randomized trials have compared neoadjuvant versus adjuvant chemotherapy for mesothelioma specifically, so most evidence comes from retrospective studies that look back at what happened to patients who received different approaches, or small prospective series from individual centers might exist. For pleural mesothelioma, practices vary widely. Some centers routinely give neoadjuvant chemotherapy before PD surgery. Others proceed directly to surgery and give adjuvant chemotherapy afterward. Some use both. Evidence suggests that receiving chemotherapy at some point, whether before or after surgery, improves outcomes compared to surgery alone, but whether timing matters significantly is unclear at this point. For peritoneal mesothelioma, the traditional approach has been surgery first, cytoreductive surgery with HIPEC, followed by adjuvant systemic chemotherapy. HIPEC during surgery provides regional chemotherapy, then systemic chemotherapy afterward addresses any microscopic disease that's spread beyond the peritoneum. Some centers are exploring neoadjuvant chemotherapy for peritoneal disease, particularly for patients with borderline resectable disease or high PCIs. If chemotherapy shrinks tumors and lowers the PCI, then complete cytoreduction becomes more achievable. What are the practical considerations? With neoadjuvant chemotherapy, surgery is delayed 2 to 4 months while chemotherapy is being given. For patients with slowly progressive disease, this is fine. But if the disease is aggressive or causing severe symptoms, delaying surgery might not be ideal. Another consideration is that chemotherapy can cause side effects that might affect surgical candidacy. Kidney damage from cisplatin, blood count suppression, or poor nutritional status related to chemotherapy side effects could make surgery riskier. Also, the disease might progress during neoadjuvant chemotherapy despite treatment, rendering previously resectable disease unresectable. With adjuvant chemotherapy, the main risk is that surgical complications, slow recovery, or post-operative debility might delay or prevent receiving chemotherapy. If you're supposed to start chemotherapy 6 to 8 weeks after surgery, but you have prolonged ileus, infections, or just a slow recovery, chemotherapy could be delayed for months or might not be possible at all. Some patients never recover adequate performance status to receive adjuvant chemotherapy, meaning they get surgery alone without the benefit of systemic treatment. How do oncologists decide between neoadjuvant and adjuvant approaches? Both patient and tumor factors guide these decisions. For clearly resectable disease with no concerning features, proceeding directly to surgery followed by adjuvant chemotherapy is reasonable. For borderline resectable disease, neoadjuvant chemotherapy to shrink tumors makes sense. For aggressive symptoms requiring urgent intervention, having the surgery first provides symptom relief. For slowly progressive disease without urgent symptoms, neoadjuvant chemotherapy is feasible. Patient preference matters too. Some patients strongly prefer getting the surgery done first to remove all visible disease. Others feel more comfortable testing chemotherapy's effectiveness before committing to a major surgery. Center protocols and the surgeon's preference also influence decisions because some surgeons have strong preferences based on their experience. If you're at a center where the multidisciplinary team has good outcomes with one approach or the other, following their protocol makes sense. What if you receive neoadjuvant chemotherapy and your scans show progression? This is actually valuable information because it tells you that the tumor is resistant to that chemotherapy regimen and it's aggressive. Surgery might not be worthwhile if your disease is progressing despite chemotherapy treatment. Alternative chemotherapy or immunotherapy could be tried, or you might want to shift your focus to palliative care rather than aggressive surgery. What about perioperative chemotherapy, which is both before and after surgery? Some centers use this approach, giving 2 to 3 cycles before surgery and then proceeding to surgery and then giving additional cycles afterward. This combines the potential benefits of both approaches, but it also means longer total treatment time and a greater potential for cumulative toxicity from the chemotherapy. What questions should you ask about chemotherapy timing? Why are you recommending neoadjuvant versus adjuvant chemotherapy for my case, or vice versa? What are the alternatives? If I have neoadjuvant chemotherapy, what would make you decide to proceed with or cancel surgery? If I have surgery first, what's the likelihood I'll be able to receive adjuvant chemotherapy? What does your center typically do, and what are your outcomes with that approach? To review, neoadjuvant chemotherapy is given before surgery to potentially shrink tumors, test treatment effectiveness, and address micrometastatic disease while patients are still strong. Adjuvant chemotherapy is given after surgery to eliminate microscopic residual disease. No definitive evidence proves one approach better for mesothelioma. Neoadjuvant chemotherapy makes sense for borderline resectable disease or to assess chemotherapy response, while having adjuvant chemotherapy avoids delaying surgery, but also risks patients not recovering enough to tolerate chemotherapy after the operation. Some centers use both, which is called a perioperative approach. The decision depends on the cancer's resectability, disease aggressiveness, symptoms, patient health, and center protocols. You can visit mesothelioma.net for more information about different approaches to chemotherapy for mesothelioma, or call 1-800-692-8608 or use the live chat feature to work with one of our patient advocates immediately. As for me, remember to post your questions below, and I'll see you next time.